and mathematically then provide much better information to show whether or not a treatment was valuable, even though the patient wasn't able to make that last follow-up visit. All of this will reduce the cost of clinical trials. The last trial we did, we just published in the New England Journal of Medicine, was a treatment for stroke, for walking recovery, and it was a $12 million study, and $6 million of that was meant to basically follow up patients and bring them in and check them and send out people to make sure they were doing what they were supposed to do. With wireless sensors, I would anticipate we could cut that cost by 90%. Be a huge savings. It means you can do more trials of more interventions and still have better monitoring and outcome measures along the way if the sensors are working properly. And all of this is going to give us better access to patients because we can now bring in patients who live far away and can't make it in for that 100 miles to the center that's doing the study, even though they would like to participate. And we can combine a little bit of telemedicine, look at the patients, they can hold up their smartphone, we can see what they're doing, we have measures that we're monitoring, we can talk to them face to face to keep them involved and compliant in the study. This is just going to make doing clinical trials much, much easier for any disease and for any intervention. And then we have the whole issue of daily care. We give people recommendations, and do they follow them? And for the most part, people who are well are not so easy to convince, they feel well, it's not so easy to convince them to manage their high blood pressure or their diabetes optimally, or to try to improve their fitness. And so these sensors for daily care that were described by Paul are